Das ist, was können die?
Das ist 10.
Ah, ist gut. Ist gut. Es sind ja noch gar nicht alle da. Ja, eine ganze Menge Leute, die noch nicht da sind. Das wollen sie nicht sein. Ah, hier.
Doch, hallo, guten Tag, Herr PITZEN.
Hallo.
Aldar ist mein Name. Wir warten auf den Start.
Hello,
Ja,
sir.
kein Problem.
For a long time I haven't seen you. Hello.
Dr. Hassanein, how are you?
Perfect.
Thank
Very
you.
good. So now I think we should start. Imad?
Yes,
Can
sir,
you
we can
start
start.
recording? We can start?
Yes, sir.
Okay.
Yes, sir,
So
it's
we
fine.
go online now. Perfect. So, well, good afternoon to everybody. It's a pleasure for me to have this webinar of the World Spinal Column Society. It's a wonderful webinar this time. It's focusing on the cervical spine. And I'm very happy that we have changed the format a little bit. So we will have 2 presentations and then 3 cases. So it will be a lot of information, but I think it's better because then we have the basis to discuss the cases. So I'm very happy that I have 2 real experts for cervical spine surgery. And the first one is TOBIAS PITZEN. He is a very experienced spine surgeon, has been actually graduated from Hamburg University, but before I was here, so long ago, with spine surgeon in Eastern Germany, and now he followed the Harms in Karlsbad Langensteinbach. I think maybe for 15 years now he is there, the head of spine surgery, neurosurgery. So it's a real pleasure. He's very experienced. He has done a lot of research. He has worldwide expertise. So Tobias, I hand over to you to give us your presentation on the cervical, craniocervical junction and pedicle versus lateral mass screw placement.
Yep. Thanks, Joachim. Hi, everybody. Can you hear me? We got some little problems with the microphone here, but I hope you can hear me. Is it yes?
We can hear you, yes.
Audio is very good. It's very good.
Super. Okay. So yeah, with the slides, I do not know. Do you know how that works here so that you can see? Look at that. It is now too. Okay. It's much too much. Much too much.
Go on the presentation mode.
Yep.
Down.
This one?
Yeah, there.
Thank you.
Yeah, that's it.
Thank you, Joachim. Thank you. Okay, so let's start. As you said, it was wished to present cases on the basis on that, to talk a little bit about the cervical spine posterior stabilization, including the CCG. And let's start with this case. This is a 18-year-old male with a severe neck pain following a struggle with friends. He had a kyphotic and tilted head position and then a destruction of the caudal clavus down to the body of the axis. You can see that here on the left side, it's a CAT scan. On the right side, it's the MRI. I see my friend Hassani there. We have been operating on cases like that several times, but this was very special in several aspects. So here is more information on MRI and CAT scan. You can see that the lateral mass in the atlas is destructed enormously, and that the vertebral artery on the left side, at least on the left side, is included. So you can see it on the right side here, on the left side, it's somewhere in between. So it's a big mess. I think we have to think about patients in detail. The first question we have to answer is, do these patients need surgery, yes or no? I mean, that's the reason why we are here, yes. But if yes, how to start? What levels to be included? Do we go back, front, both? What type of implants do we use? And is there any place or necessity for additional treatment? How to start and levels to be included is probably one of the easiest questions. I think everybody of you will agree when I say a biopsy is a must here to treat these patients, because we have to know what tumor that is. I, from my personal experience, was confronted with that type of tumor for the first time in my life This was an inflammatory myofibroblastic tumor, a very rare entity on the spine, even more rare in the craniocervical junction. So there have been just a handful of cases published all over the world. However, it is aggressively growing entity. And I thought due to that destruction mass, it was mandatory to fix and realize and stabilize the cervical spine from the occiput down to C4, 5, or 6, just depending with the caudal end of the fixation on the bone quality and the resulting screw torque. I think everybody could agree here. So this is what we did in the first step. So we just took that guy, got him in the OR, did the biopsy, and then fixed it because it was terribly unstable. And now, if you do that way, you have further time to plan further treatment. The type of implants I used up to now here, so that's why I call it part 1, is occiput-bladed screws because the occiput is involved. And then I use lateral mass screws C1 to C5 due to the good bone quality. But I think the much more important aspect here was that the tumor involves the left-sided vertebral artery. I could show you that. And taking into account that you could hurt the vessel during resection, which would be, I think, very probable, and it was really the case, then it's probably better not to use a pedicle screw due to higher risk of hurting the vessel also on the other side. I think that makes sense. You can see this is not just something I experienced. This is from a publication from NEO in 2005 about the clinical risk of vertebral artery injury from the cervical pedicle screws inserted in degenerative spine. And you see that the pedicle screw can harm the vertebral artery. And what the authors concluded is that the deviation rate of the cervical pedicle screw placement is not very seldom, and they strongly recommend, if you do that, use a computer-assisted navigation system, or today, robotics. We can discuss about that later on. Concerning occiput screws, I think it's much more or less traumatic, especially for neurosurgeons, but you should be familiar with the anatomy of the occiput, which is thickest in the midline, and that's why I consider good systems with occiput blades to fix the screws exclusively in the midline, not laterally, exclusively in the midline, because the bone is here thicker. Here are some X-rays and CAT scans post-op, so not from this patient, but from other patients over my time, concerning the fixation of the occiput straight into the midline. What is also important in occipital-cervical fusion procedures is that you have to check the sagittal alignment and the gaze. So if you fix the occiput straight to the spine, then usually the gaze is horizontal and forward. If you recline too much, then the gaze is towards the sky, and if you incline it too much, the gaze is towards the bottom. The latest one is very, very dangerous because this has immediate implications for dysphagia and apnea. And we know that a reduction of the occiput C2 angle of more than 10 degrees results in a relevant dyspnea and dysphagia. And this is possibly life-threatening. If you're not familiar with that, please read these 2 publications which are mentioned here. Concerning the strength of pedicle screws, it's quite clear that pedicle fixation is stronger than facet fixation. I mean, it's quite clear because these pedicle screws are just double as long as the facet fixation. But facet fixation is sufficient in the presence of good bone quality and especially in the presence of an anterior support. So if you insert a cage or a cage with a plate, then you can be sure this will be, I would not say bulletproof, but it's probably very, very close to an isolated pedicle screw instrumentation via posterior approach. So it comes from my clinical experience of about approximately 30 years. Concerning complications, it's very clear, facet screws are much more or less dangerous than pedicle screws. You can check these results by a check-on, and you can check the paper by Kass and Berm in the European Spine Journal. They describe pedicle screws in the C-spine to be misplaced by approximately 30%. The other question in our case, we go back to our case in the clinics, is back, front, or both, what type of implants? So part 2. Back, front, or both is easy to answer. It depends on the localization of the tumor. This tumor is located back and front, so you go back and front. But the thing is, you have already closed the wound, so you have to reopen the wound. You have to resect the tumor by a posterior approach, and we, in a very initial step, did an endovascular embolization and then removed the tumor step by step. And then in the same day, we did a high anterior approach and anterior section. And we here used no titanium implant, but an autologous fibular graft fixed with a small bone plate. Radio treatment using protons. Next, we applied a halo body jacket for the next 4 months. The reason is I could not fix the fibular strut at the skull base with appropriate screws, and I really feared it would dislocate. So I was confronted with the situation that you have one shot here, no more. So 6 weeks after surgery, you can see the fibular cuff in place, and it's fixed with the small bone plates, and you can see the posterior construct, and you can see the halo here in place. And you can see that result. This is now 2 years after surgery, and it's with an ongoing cytostatic treatment. So this guy is coming in every 6 weeks, checking, and it's really perfect. We go on with this case. This is a 10-year-old girl with a progressive tetraparesis with loss of ambulation. She has a concomitant dysplasia, and I know my friend Mohammed Atala is an experienced orthopedic surgeon. Mohammed, do you have any idea what this could be from a point of diagnosis?
Difficult to tell.
I didn't get it.
Difficult to tell, actually.
Yeah. I thought maybe you have seen one of these or more of these patients in our hospital here. Now, if you know, you have this C-shaped kyphosis here and concomitant hip and knee dysplasia. This is a case in which the vertebral posterior aspects are not connected to the anterior ones. And this is typical for a so-called Larsen syndrome, which is a genetic disorder with numerous skeletal manifestations. And because the posterior elements in the spine are not connected to the anterior ones, you have a progressive kyphosis or olesthesis and a progressive tetraparesis. And that's why you just have to about in detail again in this patient. Surgery, yes or no, yes, what else? I mean, that's the reason why we're here. What levels to be included? I mean, you just check the X-ray and you say, okay, from the upper spine to the upper thoracic, upper cervical to the upper thoracic, front, back, or both. I think back first, but front, let us see later on. What type of implants to be used? I mean, here, pedicle screws are great. Why? Because pedicle screws connect the posterior part to the anterior part. That's why here, lateral mass screws don't make sense. So you have to use pedicle screws here because the pedicle screws replace the function of the pedicle. And in case of using pedicle screws, navigation or robotics is a must. Atala, you know, most surgeons will tell you so. And a must, I don't know, because we do not own such a tool, and I do that usually without a robot. The reason is I don't have one. Think about a patient in detail, part 2. The anterior aspect here is a hypomachleon acting against the spinal cord. And that's the reason why I call here for an anterior approach is high cervical spine discs will overload an isolated posterior fixation, and you have a space encroachment from the anterior aspect. That's why go from anterior here too, do an anterior resection of the space encroaching processes, do a correction, fixation, and fusion, I think, is a must here. Otherwise, it will fail. So I did the decompression, fusion, C3 to 4 using cages, autologous bone, and the plates. After surgery, she really regained walking ability. And you can see the MRI after surgery and the concomitant X-ray in the lateral aspect. Just a few final remarks to cervical pedicle screws. It's not a new technique. It's almost 30 years old by Abumi. The entry is very lateral at the upper edge of the facet. And the trajectory is characterized by a very high angle of convergence. You have a risk for vertebral artery damage. Just if you see that plastic bone, you can see it's true. That's why pedicle screws are best for C2 and C7 pedicle, simply because the vertebral artery is no longer medial. I strongly recommend to perform a CAT scan angiogram before surgery. You always have to do the good side first. The good side is the side with the thin vessel and the thick bone. And there is one major thing you should know. In case of vertebral artery injury, never touch the other side. Never do, never do. Finally, take-home messages. So posterior fixation to the C-spine is challenging due to small bone dimensions and the presence of the artery. Take into account that even routine surgery may develop into a big disaster. Never underestimate this. Perform a CAT scan angiogram before you start and do a biopsy in case of tumor. Fix occiput plates within the midline. Use lateral mass screws whenever possible. They are safer. Consider anterior supports in case of exclusively using lateral mass screws. Pedicle screws are great at the level of C2 and C7. If you plan to use pedicle screws between C3 and 6, be very experienced and/or use navigation or roboter. Finally, plan your surgery. Plan your surgery. Work slowly and, if necessary, in an interdisciplinary approach. Thanks for listening.
Thank you, Tobias. As expected, it's a wonderful comprehensive overview for the pedicle screw and the lateral mass screw and the craniocervical junction. I think it's perfect for the 3 cases we will present. And we will put all the questions later on. The next, we just move on with the next presentation. And this is Dr. Atala Hassanain. He has been with us at first in Karlsbad, Langensteinbach, I think with you for 3 or 4 years, and then maybe for 5 years with us. And he is now in Riyadh, head of the spine section, a very new hospital, just started there. And he will present to us his, basically his research results for over the last 5 years about the particular insertion of the